right. So without further ado, I'd like to welcome future Dr. Amanda Shepard to the screen. She's going to be talking about early intervention and I'm sorry, not about early intervention. She'll be talking about assessment tools in outpatient clinics and how they relate to occupation-based practice. Amanda is in the occupational therapy post-professionally doctorate here at Elizabethtown College and is doing an amazing job. So without further, I'm going to turn it over to her. She'll talk for about 25 minutes and then we'll give about 5 minutes for questions. It's all your turn. Go for it, Amanda.
Alrighty, thank you for the introduction, Carrie, and thank you so much, everybody, for being here. I think I'm just going to hit got it here real quick so that we're not seeing that in the middle of the screen. So thank you, everyone, for being here. I'm looking forward to sharing the results of my capstone presentation with you. So the title of my study was Retrospective Documents Review, exploring the impact of initial and post-assessment on occupation-based outcomes using occupation-focused assessment tools compared to developmental-focused assessment tools for children aged 3 to 5 receiving outpatient occupational therapy. Oh, let's see if it'll let me move forward here. There we go. Sorry. So the primary purpose of my study was to further investigate the discrepancies between occupation-based practices and problem-oriented approaches that I found embedded throughout the literature. By exploring assessment tool choice as a potential barrier or facilitator to the successful implementation of AOTA's best practice occupation-based approaches to the OT process within the context of an outpatient therapy clinic. Specifically, my research question was, did the use of an occupation-focused assessment tool administered throughout the OT process demonstrate increased occupation-based outcomes when compared to the use of a developmentally focused assessment tool? Specifically, I looked at the Miller Function and Participation Scales, or the MFUN, as the occupation-based assessment, and I looked at the Peabody Developmental Motor Scales, or the PDMS-2, as the developmentally based assessment tool to study within the context of this research study. My hypothesis was that children aged 3 to 5 who participated in occupation-focused assessment tools would demonstrate improved occupation-based outcomes and goal achievement in comparison to children who participated in a developmentally focused assessment tool at the time of both their initial evaluation, as well as either reassessment or post-assessment at the time of OT discharge. A general kind of brief overview of my actual research procedures. The context of the study was at an outpatient therapy clinic. The methodology was a retrospective document analysis to draw conclusions using theoretical associations and thematic analysis as the framework for reviewing study data. I did receive consent from both Elizabethtown and the healthcare where I work and conducted this study, the institutional review boards of both of those facilities under exempt status. And under exempt status, I was also granted a waiver of parent consent and child assent due to the secondary data analysis nature of the study. All of the pediatric client information was completely de-identified. Therefore, it kind of posed minimal to no risk to the research participants. After I obtained the approval for the study, I was able to move forward with data collection and data analysis, which we'll get into now. So the inclusion and exclusion criteria for my study, the child had to be within the age range of 3 to 5 years. They had to have participated in either the MFUN or the PDMS-2 at both their initial OT assessment, as well as either their reassessment or post-assessment at discharge. They had to have completed their OT plan of care with the principal investigator, myself. I did not exclude any languages for this research study because at my outpatient clinic, I had interpretive services consistently available. Some other reasons that a child might have been excluded from the study were if they were picked up by another clinician. That happens pretty frequently in outpatient where I may have evaluated the child, but due to scheduling needs, the family is seen by another therapist. Another big reason why a child might have been excluded from this study was if they did not engage in a reassessment or post-assessment because they were discharged early due to an unexpected reason. Some of those reasons might have included a financial barrier, an insurance barrier, or sometimes it was because they were discharged back to school-based therapies. So taking a look at my overall population sample here, my initial sample population was obtained from a data analysis specialist at the healthcare organization where I work. They provided me via automated text analysis, with an initial randomized sample of 53 pediatric clients' medical charts. From there, I went ahead and applied the exclusion criteria as necessary, and I had to remove 36 of the charts, mostly because of that reason of them being transferred to another therapist. So I was wound up with 17 medical charts that I had in total. And as you can see there, again, all of these patient charts were completely de-identified, but out of the 17, 7 completed the MFUN and 10 completed the the Peabody. So not an even 50-50 split, but not too far off, which made it nice for comparison purposes. So getting into my data analysis, the heart of my data analysis revolved around a research tool, a questionnaire that I designed titled the Retrospective Chart Analysis Questionnaire. I'm going to pull that up in a minute so you can see it, but the first question separates each of the medical charts into either Group A or Group B. Group A included any of the pediatric clients that I worked with who did the MFUN. Group B represented any of the clients who completed the PDMS2. So I know this is a little small. I'm sorry for that. I tried to make it as big as I could to keep it on here, but get the whole thing on here so you can see it in its entirety. This is the retrospective chart analysis questionnaire that I used and filled out for each one of those 17 medical charts to complete the retrospective documents review. So as you can see, there are a total of 5 questions here. They're all closed-ended. The first one separates each chart into Group A or Group B. And then the rest of them are focused on different categorical variables that I study throughout the rest of this presentation, and I'll go over them. But just so you can see, the first categorical variable was related to whether or not occupation-based goals were present at the child's initial OT evaluation. The second was if occupation-based areas of need were identified in the occupational profile at the child's OT evaluation. The third was if the child's chart included occupation-based areas of improvement at either reassessment or post-assessment. And the last categorical variable was if the child had the presence of occupation-based goals achieved at the time of reassessment or post-assessment. So data analysis itself, I conducted in 2 phases. Phase 1 was bivariate analysis, where I applied the Fisher's exact test to calculate a p-value and explore any potential for associative significance between Group A and Group B and any of those categorical variables I had just discussed from the retrospective analysis questionnaire. Phase 2 was trend analysis, where I took each of the medical charts and assigned a score on a corresponding rating scale that was based upon the categorical variables from that same retrospective analysis questionnaire. And then I plotted them on a scatter plot, and you will see all of that shortly. So let's get into the results. So we're in phase 1 of data analysis here. And if I can draw your eyes to figure 1, we're going to be looking at that first categorical variable I had discussed. So the comparison of occupation-based goals in the charts of Group A versus Group B. So you can see Group A and Group B at the bottom and the numbers of charts on the side, but I want to draw your eyes to the light blue bar. That represents the number of medical charts where occupation-based goals were marked as achieved at the time of the child's reassessment or post-assessment. The dark blue bar represents if a child's medical chart, how many medical charts after retrospective documents review, occupation-based goals were not marked as achieved at the end of their plan of care or reassessment. So Group A specifically, 7 of Group A, or about 41.82% of the total sample, did have occupation-based goals marked as achieved at the end of their plan of care at reassessment or post-assessment, whereas Group B, 3, or about 17.65% of the total sample of medical charts included the presence of occupation-based goals marked as achieved, whereas 7, which represents about 41.18%, of the sample did not include the presence of occupation-based goals marked as achieved. And when I applied the Fisher's exact test to this particular group of data, I received a p-value of 0.0098. Just for reference sake, in order for a result to be significant, it had to be less than 0.05. And in this case, it was. I'll go into the interpretation later on in discussion, but just for reference sake, it was a lower number. So we're still in phase 1 of data analysis, where I was using bivariate analysis as the methodology to go for data analysis, but we're looking at a different categorical variable now. So now we're looking at the comparison of the presence of occupation-based areas of need at evaluation and the presence of occupation-based areas of improvement at post-assessment or discharge in Group A compared to Group B. So if I can have you look for at figure 2 here, you can see, similar to figure 1, the light blue bar represents the number of medical charts where occupation-based areas of need and occupation-based areas of improvement were identified throughout the OT process. The dark blue bar represented medical charts where occupation-based areas of need and occupation-based areas of improvement were not identified throughout the OT process. So specifically in Group A, 7 of the charts, or about 41.18% of the total sample, did have occupation-based outcomes present throughout the entire OT process. In Group B, 2, or about 11.76% of the total sample of participants' medical charts, included the presence of occupation-based areas of need at their evaluation and occupation-based areas of improvement at reassessment/post-assessment. Whereas 8 of them, about 47.06% of the sample, did not have those occupation-based outcomes present throughout the OT process. When I applied the Fisher's exact test here, it resulted in a p-value of 0.0025, 23. And once again, that is below the less than 0.05. And just for context sake here, the Fisher's exact test, I will go into this more into the interpretive part and discussion, but just to kind of go over what its purpose is, the main purpose of the Fisher's exact test is to demonstrate the likelihood of observed frequencies and expected frequencies, to demonstrate whether or not a result was more likely to happen by chance or more likely to happen because those two variables you explored did have a positive association with one another. So moving into phase 2 of trend analysis, once again, we're going to be comparing categorical variables to Group A and Group B, but if I can have you take a look at figure 3, this is when we did that trend analysis to plot the different categories of data. So the light blue diamond represents Group A, the dark blue circle represents Group B. And you can see the corresponding rating scale below. In Group A, 7 out of 7 of the charts, or about 100% of Group A, received a rating scale score of 2 for occupation-based goals being present throughout the OT process. In Group B, about 30% received a rating scale score of 2, 60% received a rating scale score of 0 for not having those occupation-based goals at eval or at post-assessment. And there was one outlier that achieved a rating scale score of 1 in Group B, and that represented about 10% of Group B. The last trend analysis I completed was looking more, once again, at the presence of occupation-based areas of need and occupation-based areas of improvement identified throughout the OT process. Same symbols here, blue diamond for Group A, dark blue circle for Group B. So in this case, in Group A, once again, 100% of Group A received a rating scale score of 2 for having occupation-based areas of need and occupation-based areas of improvement identified throughout the OT process. And in Group B, about 20% of them received that same rating scale score of 2. And the rest of the group was split between 40% received a rating scale score of 1 and 40% received a rating scale score of 0. I do want to bring your attention to that subgroup of the 4 members of Group B that received that rating scale of 1. Just for further information's sake, about 75% of those received that score because occupation-based goals were identified at the initial evaluation, but they were not present as, areas of need were identified at the initial evaluation, but occupation-based areas of improvement were not identified at post-assessment or reassessment. So let's get into the discussion. So for my hypothesis check-in, both of the phases of my data analysis revealed a pertinent cache of evidence supporting the alternate hypothesis within this small sample population only. It's really important that I start right out of the way with this was a very small group of participants, so these results cannot be generalized to a larger population. So the results really are significant within the confines of this smaller group. But both results of bivariate analysis and trend analysis indicated minimal evidence that Group A yielded more consistent presence of occupation-based areas of need at evaluation, more consistent presence of occupation-based areas of improvement identified at reassessment, post-assessment, more consistent presence and achievement of occupation-based goals. And bivariate analysis indicated that there was a higher likelihood of there being a positive association between the use of occupation-based assessment tools as the chosen outcome measure and occupation-based goals being more consistently identified as achieved at the time of a child's reassessment or post-assessment. I did want to take a minute to briefly talk about specific implications for children with autism spectrum disorder. 8 of the 17 cases here did have autism. 2 participated in the MFUN, 6 participated in the PDMS-2. Both of the pediatric clients with ASD in this study who participated in the MFUN achieved their occupation-based goals. And in comparison, out of the 6 clients with ASD who participated in this study and who completed the P-body, 1 of the 6 of these patients had occupation-based goals marked as achieved at the time of their reassessment or post-assessment. So results of the present research study appear to be in accordance with previous literature that supports top-down or occupation-based approach to evaluating children with ASD, as evidenced by the MFUN's more consistent achievement of occupation-based outcomes in comparison to the PDMS-2 or more developmental approach. So what barriers exist that could be limiting the use of occupation-based assessment tools at the time of OT initial evaluation, reassessment, and post-assessment? So there certainly were many that I found, but I wanted to go over as many of the highlights as I could. One of the most significant being the relationship and influence of caregivers on the dynamic relationship out of evaluation between the caregiver, the client, and the OT practitioner. That's certainly a very dynamic relationship, and it can have a big change agent throughout the OT process. To give a good example of this, when I completed the retrospective chart review, there was a significant similarity between all 3 of the medical charts in Group B, where occupation-based goals were marked as achieved. This was particularly interesting because these goals were either addressing or feeding skill goals, so ADL skills. And that was interesting to me, particularly because the P-body doesn't have any components where you have the ability to test those ADL skills. So one of the potential rationales for why that happened was, I'm speaking from myself, these were my previous patients. So I know more than likely the reason that happened is because the parent brought it up at the initial evaluation that it was an area of concern. So I would have developed the goal to be in compliance with best practice of family-centered practice. However, that doesn't support making sure that we're evaluating with an occupation-based approach at that point. But once again, that kind of highlights the discrepancies that I found between OTs valuing occupation-based practices and actual service delivery choices. Other potential reasons and barriers could have been lack of robust research guiding OT practitioners on assessment tool choice to support objective occupation-based outcomes and meaningful occupations, as well as outpatient-specific barriers such as payer stipulations and reimbursement challenges, the common use of developmental and medical frames of reference to guide the OT process in outpatient, as well as limited time allotted for outpatient OT evaluations. Specifically, I can mention in my own experience, I'm given about an hour to complete OT evaluations, and both of the manuals of the PDMS-2 and the MFUN list that the average administration time is about 45 to 60 minutes. So it doesn't leave me with a whole lot of room for more targeted engagement and just the occupation of play with a child at eval. So conclusions, I'm getting to the end here. So my hypothesis conclusion was this research study included only a small sample population, which limited the ability to generalize results to larger populations. However, the results are significant as they provide minimal evidence that choosing an occupation-based assessment tool may support more occupation-based outcomes during outpatient occupational therapy plans of care. Specifically, the results indicated more consistent presence of occupation-based areas of need and areas of improvement identified throughout the OT process, higher rates of achievement of occupation-based goals throughout the plan of care, as well as minimal evidence of more consistent occupation-based meaningful outcomes for children with autism spectrum disorder within this small population study. And really the biggest take home for me from this study was that this research study is just a pilot, but it really provided a sound stepping stone, kind of keeping us on the path towards AOTA's big vision for the profession, for having more objective, but still maintaining that big value in our hearts of having an occupation-based approach to our therapy services, so that we are helping our clients to achieve their meaningful occupations. Lastly, I just wanted to go over the limitations of my study briefly. Some of the most significant being as I mentioned, the smaller population size. There were only 17 charts here. And so I definitely would have benefited from having a larger pool of charts to compare. There were also some potentials for bias limitations. Specifically, these were my previous patients' charts. So even though they were completed retrospectively, it still leaves some room for interpretive bias, as well as the retrospective questionnaire was developed by myself. So that does leave some opportunity for interpretive bias as well. Future studies really should prioritize minimizing these potentials for bias in the research by expanding upon the sample size, and also maybe including the charts of other OT practitioners to provide a larger base of support and potentially increase the effect size of the study. And these are my references for the PowerPoint. So thank you so much, everybody, for your time. I'm open to any questions that anyone has. I know I don't know where we were on time. I'm sorry.
There's about 7 minutes. So you have some time for questions if folks have any. They are welcome to put them in the chat bar. I can monitor that. And they're also welcome to just raise their hand or unmute and speak out. Either one and anything they'd like. I'll give everyone an opportunity.
Hey, Amanda, this is Sue. It's a wonderful presentation. Thank you.
Thank you.
I have a question. You had mentioned kind of how your research was supporting AOTA's Centennial Vision from 2020. How do you feel it is supporting Vision 2025 that's now in effect?
Yeah, that's a good question. I mean, that's certainly something that, that vision is constantly dynamic and changing for us. But I think one of the biggest things I know in my daily practice, it's just the focus on making sure that we are getting a little bit more objective with our approaches to our practice, and not just from not trying to focus on those performance skill aspects of it so much, but more just making sure that we're having the evidence base that we need to move forward and push the profession forward. I feel like that's not just specific to 2020, but for 2024 as well. It's kind of this little invisible thread that's been connecting us all these years to just keep getting more objective with our approaches to evaluation, because we're getting more and more, at least I can speak from an outpatient perspective, we're getting a lot more pushback from reimbursement and even which diagnosis codes, things that we can put in there. So they're getting even more critical of that. So to make sure that we still have a seat at the table, making sure that we're keeping our values the same, but still being able to still play ball in the medical field.
Thank you.
So I'm going to put you on the spot a little bit. Most OTs who go for their PPOTD say that statistics is like their daunting, like they don't like the statistics, and you have a whole lot of statistics in here.
I know.
So tell me a little bit about what your your biggest barrier and your biggest success were when you were dealing with all those numbers.
Yeah, I can speak and mirror and echo exactly what you just said. I am a pediatric OT. I like to live in the gray area of things. I avoid black and white as much as I can sometimes. So although I always appreciate the statistics when I read them, being able to implement them myself was definitely the most significant barrier that I had, especially when I was faced with a smaller population to work with. It was a little painful going from 53 down to 17, but I wanted them all to have equal opportunity, but I also really wanted to make sure that I was following that specific inclusion and exclusion criteria to a T. But it took a lot of reaching out to different resources, both different professors on campus and different resources, both in statistics and math and our OT literature. So that was definitely the biggest challenge, was finding the right statistical tools to demonstrate what it was that I was trying to demonstrate, and not just be a bunch of math on the page. I wanted it to show the significance and why it's still valuable to us as OTs. It has to mean something. They can't just be numbers. So that was definitely my biggest challenge. And I guess to kind of piggyback off of that, I would say my biggest success was finding a statistical test that really did suffice and was the Fisher's exact test itself is perfect for smaller populations studied. If I had a larger one, I could have used more of a chi-square as another type of bivariate analysis, but the result was still the same. It demonstrated that these results were very unlikely within this group to have happened by chance. It was much more likely that Group A and Group B really did have an influence on those different categorical variables. So it made me like statistics a little bit more, to be honest.
You speak of them very well, so you do not have a confidence problem with it. Compliments to you. Are there any other questions in the group? Otherwise, we have 3 minutes until we'll start a different presentation. I think you're off the hook, Amanda. Nice job. Very nice job.
Thank you, everybody.
Okay.
All right, so I'll stop sharing.